Welcome to the Global Robotic Assisted Surgery Podcast, or GRASP for short. We release weekly podcasts featuring insights from leading surgeons and other surgical professionals. Our host for today is Professor Hitendra Patel, who is a global key opinion leader in robotic assisted surgery, a global key opinion leader in telesurgery, and editor-in-chief of the World Journal of Clinical Oncology. We hope you enjoy the GRASP podcast.
Welcome to the Global Robotic Assisted Surgery podcast. I'm Professor Hitendra Patel, and I'm delighted to have a global expert in the world of robotics and hepatopancreatico-biliary surgery. Dr. Aamir Khan, welcome to the podcast.
Thank you very much, and thank you for having me.
It's our pleasure. Now, just a little bit of background about Dr. Khan. He's spent many years, over 15, in a major teaching centre for cancer care in London. He's also travelled the globe and training in Europe and other places. So we're very fortunate he's here tonight, and we're just going to get right into it. But Aamir, before we start about robotics, I love to know, and so do my guests, and so do my people watching this podcast, they love to know, how did you get to where you've got to? You're clearly a very talented man in a very high position in life. So how did you get there as a surgeon? A lot of the people on this podcast really would love to
know. I started off as a young consultant at the Royal Marsden Hospital. I was the second of the two hepatobiliary surgeons, hepatobiliary, pancreas, and other surgical oncology, and slowly built up this practice. And I was very fortunate to be the first wave of robotic surgeons in the United Kingdom. I think in 2009, I visited the robotic unit in Chicago with Professor Giulianotti. And as far back as that, I could see that this was the future, because it was the world of technology and the world of virtual reality between the surgeon and the patient, facilitating what could be done for the patient. And it became clear to me at that point in time that this was the interface that would allow a larger number of patients to be offered the option of minimally invasive surgery. Now, you know very well from your own experience with minimal access surgery that not only does it offer better vision in difficult areas of the body, but it also offers faster recovery, much better cosmetic appearance, and shorter hospital stay for these patients.
Yeah. So let me just, if we just split this up, because like a good urologist, the HPB surgeon has to work on the liver and the pancreas and the biliary system. There's three systems. Yeah. So I think for the listeners and the viewers, let's just split this up for a second. So if you don't mind, let's talk about the pancreas first, and let's just talk about the Whipple's operation, the most complex surgery known to mankind in that area of the body. Let's put it like that. Tell me what you think about Whipple's and robotics.
So today's generation, which is the sort of third or fourth generation robotic platform, is very suited for complex retroperitoneal surgery, i.e. the Whipple operation. Because when we started with the robotic Da Vinci S, and I used that, it was not really suited for complex surgery of the sort that you've just mentioned. The arms, the positioning, the instruments, they were just not suited. In comes the SI, the second generation. And along with the SI came better tools, second generation tools, energy devices started coming on, becoming more refined, and our experience with that hybrid operation where the assistant was also using a laparoscopic energy device, the suction, the dexterity of the instruments, that came on. Fast forward another few years to the XI platform. And that's when the third generation tools came on that really were suited for this sort of surgery. Because you know as well as I do that the problem with retroperitoneal surgery, the problem with the Whipple operation, operating at the depths of the abdominal cavity, was a narrow view, and B, sudden unforeseen bleeding that could really take the operation out of control. Now, laparoscopic Whipple didn't really catch on for this reason. That A, the ergonomics of a long operation, B, the risk of bleeding, would just not make it a suitable proposition. Now, with the robotic platform being used, the risk of bleeding in the retroperitoneal tissues next to the superior mesenteric vein or artery is very low now, similar to that of an open operation. Number two, the dexterity that is required for a pancreatic anastomosis, where the duct can be 1 millimeter, 2 millimeters, but the angles that you can now create with the robotic needle holder or both hands, you just cannot get that in an open operation.
So just for the audience, I'll just surmise what you just said. There are two major components to most of the complex surgeries that you and I undertake. One part is ablative, and the second part is reconstructive. Yep. And I think what you've just said is in both components, there is huge advantages with the third generation systems that you describe, not just the actual the canopy side of it, but also the dexterous little instruments. So in terms of the instrumentation from the energy sources, first of all, what's your favorite energy device that helps you the most in your third generation robotics? Which one would you pick?
So it started off with getting the assistant to use either the harmonic or the LigaSure device.
Yeah.
They're both very secure. The harmonic is a bit more dissection friendly. You can dissect with it a little bit. The LigaSure is a bit better at hemostasis. And but there is a disconnect between yourself in the sense that it is the assistant that is handling that. So you have to learn to give very clear instructions about what should be done. The second point is now with the robotic harmonic, you can have that control yourself. And there is no substitute for that. There is one other point I would like to make regarding the pancreas. A lot of pancreatic surgery is now for cystic lesions in the pancreas. First described in Japan in the mid-90s, they form a substantial part of any pancreatic center's practice. The good thing is they are small, they are picked up on incidental imaging, and they are a rare scenario in pancreatic surgery where we can offer the patient a chance at cure, where surgery alone is curative. They are often in the body or the tail of the pancreas. With laparoscopic surgery, the chance of us offering the patient a spleen-preserving operation at best is 30 to 40%. With the robot, it doubles. It is 80, maybe 90%. Because of the two things that we discussed, the vision, the dexterity, and the advancements in instrumentation. Now, splenectomy itself carries a certain degree of morbidity. and is an unnecessary part of that operation. So the robotics platform offers another advantage on that.
Yeah, yeah. I was just for the listeners and viewers, Dr. Khan spent some time in Tokyo, hence he's an expert in talking about the Japanese and what they do in surgery. Great time in Tokyo, by the way. Yes, Dr. Khan?
Very good. Very good.
They are the world leaders, aren't they, in many things, aren't they? So
yeah,
you had a good experience there, I'm sure.
Big learning experience.
Yeah, I'm sure you taught some things as well there, right? Wasn't
yes.
all learning, right? So So Whipple's fascinating because I was fortunate to be in my hospital at the time that Chris Russell was around. You know, he was a phenomenal open surgeon dealing with Whipples. He had tiny little hands which could find all sorts of places, but we're not all like him. So I think the robot has helped us all improve our ability to, perform good surgery. Now, in terms of the, you talked about this, avoiding splenectomy and avoiding complication, let's call it that. So would you say that with this, by applying laparoscopic techniques with robotic dexterity, robotic vision, you're lowering your complication rate, therefore you're improving outcomes for patients? Have you seen that really? You're an honest guy. Please be honest with us. Has robotics really improved things?
So the data does not support that at the moment. There is no randomized control trial that will show you an advantage of robotic Whipple over open Whipple when supplemented by an enhanced recovery program. In fact, the data will show that a slightly higher leak rate in the pancreatic group. I think Whipple is a difficult operation, open or robotic, and future series will show an advantage when an enhanced recovery pathway is used in conjunction with robotics. That's what I think time will show. But at the moment, no, there is no hard data.
You've raised an interesting, you always raise interesting comments, and views are excellent. I was just going to ask you, do you really think, is it your opinion that comparing an open operation to a robotic operation, do you think that's a fair and reasonable scientific thing to do? Or do you think they're completely different? It's like comparing apples and pears. What do you think?
I think we're comparing, so it's in many ways they are similar because they are cancer operations. We've got to look at cancer-related outcomes. The second thing to say is we are comparing new with established operations that have been around and refined and refined and refined over generations. So I think we've got to give robotics a fair chance. And I think in 3 to 5 years' time, we will see different results.
Okay, fair enough.
I think in my specialty, robotics will soon constitute 70 to 80% of all operations.
And of course, there are now 8 clinical robots in the world.
Yes.
Offering different types of advantages. So
yeah,
we have to find the right instrument for the right operation, right? You've already told us about the 3rd generation, but I think we've got a bit further. And yeah, well, I hope that's the case, because Whipples and morbidity from Whipples was huge in open surgery. So hopefully, So that's one of your 3 areas. So we've only just touched the edge of that. The other one is, let's go to liver next. I think that's a good one. So you want to tell me a little bit about liver and robotics and pros and cons?
Yeah. So liver surgery, the scale of liver surgery is very wide. The canvas is very big. You can have a small and metastasis from colorectal cancer, or you can have a very large one. And they both require different approaches. Now, as I mentioned, I'd spent some time in the Copenhagen unit, and they recently acquired the XI. And I was very pleased to see what I always believed could be done, that patients with small liver tumors from colorectal cancer either being done as a day case procedure or going home the next day. And I always thought this was possible because with the robotic platform, with the integration of intraoperative ultrasound, which is mandatory in the surgeon's console, they're able to localize the tumor very well and do a clear margin resection, but parenchyma preserving approach, preserving of the large chunks of the liver, and the patient going home some the same day and some the next day. And I always thought this was possible.
Hey, Dr. Khan, am I allowed to say that the urologist blazed the trail for this when we did partial nephrectomies? Am I allowed to say that?
Of course.
Let me say that. Thank you.
Of course. You know, progress is obtained when we learn lessons from friends and colleagues.
And we are your friends. I agree. That's a good one as well. I like that. So I think that whole intraoperative ultrasound is a fascinating area in robotics because people were so against it for so long, and it made complete sense for the surgeon to be in control. We started with the radiologist coming in and scanning livers and kidneys and things like that. So I remember when we helped our liver colleagues with this sort of work, they were going, "Wow, you've actually got ultrasound within your console. Beautiful." Do you use any for vascular surgeries that I do? We use dyes like fluorescein. Do you use fluorescein?
Yes, we use ICG. Very helpful in major hepatic resections when you've ligated the pedicle for one side or the other, because the liver, like the kidney, has no markings on it, and getting into the wrong plane leads to slow progress, bleeding, bile leak. So it is imperative that you get into the right plane. And that plane, once it's devascularized or the portal vein and artery are ligated, can be very faint.
Yeah.
But when you inject ICG, it just lights up. The perfused side lights up. There are two other areas of biliary surgery that I think lend themselves very well to robotics.
We'll come to biliary in a second. I still wanted to ask you more about my liver. Before we move on, I would love to hear about the biliary stuff in a second. In terms of the liver and what you've just said about ICG and about partial hepatectomy, removing or tumor excision, in any of those things where you're trying to preserve parenchyma. I had the fortune to work and operate with Dr. Honda, also from Tokyo, and he used to draw pictures of the liver venous system and then into segments of the liver before he started. Do you need to do that type of thing with the advent of intraoperative ultrasound and robotics? Do you still follow that sort of process, or not any longer?
We absolutely do, and I think it's a very important thing to do, because 50% of the time there will be an anatomical variation in the liver's biliary anatomy or venous drainage. And it's very important to have in front of you a reference chart, a reference point to understand how the veins are connected up. Not often, sometimes, the certain segment of the right liver is draining into the left. And it's important to have that knowledge where the pedicles will be, because isolating and ligating those pedicles at the front end of the operation leads to much lower blood loss and much smoother operation.
Wow. Okay. So it's good. And then with that, I'm assuming you have some kind of specific imaging you use for that, or how do you make that distinction?
So we use an MRI of the liver and a CT with dual phase contrast, arterial and venous portal phase, and that allows us to ascertain the vascular anatomy of that particular area, that particular segment, that particular lobe. Sometimes it's a trisector. That's happened. And that allows you then having almost a sat nav map you cannot go wrong.
Okay. So the other thing I'd like to ask you to do with this, it comes from the group in Pisa, where they were 3D printing from MRIs or CTs, reconstructing tumors within the liver to pre-plan how they would attempt to remove it with minimal parenchymal injury and blood loss. Are you au fait, or do you use this type of thing in your own practice, or are you?
Yes, I used it for borderline operable livers, and the precursor of this was the group from Germany, where they would produce 3D images and send it to you based on a CT, where you could look at it from different angles. If you lift the liver up and down, how you should approach it, and where other critical vessels that you could damage and run into problems with regeneration or hypertrophy after the operation were clearly laid out. It was a huge advancement for borderline operable tumors. And I understand that the group from Pisa now use that offer the same information in a different way. For the borderline bog standard, for the bog standard operation, you don't need that. But there are operations where that information is critical. It is also very useful in a particular tumor, hilar cholangiocarcinoma, a very, very difficult operation to do, where you're just at the front end and the relationship of that very small 2 or 4 centimeter tumor, because it's right between the clockwork. You need all the information that you can get.
Yeah. So can I just say, I don't believe you do anything bog standard with your skills. So but that's very humble of you to say that you do bog standard surgery. I don't believe you. But so we've talked a little bit about the planning, because liver surgery, robotics is not enough. You still have to do that huge planning, right? The preoperative planning.
The preoperative planning is the key bit of liver surgery. When you have a small one segment, 2 segments, or small non-anatomical resection to undertake, you can do it any which way you want. The patient will get well, the patient will go home. It's when you are doing the big stuff. It's when you are doing tumors of the hilus, or you're operating on chemo-injured liver, or liver damaged by cirrhosis from whatever cause, when you need to be very accurate in removing what is needed and preserving what is needed. Because in liver surgery, after a while, you understand it's not what you remove, it is what you leave behind and how well that functions. Because the liver is the main engine powerhouse of the body, which if the liver fails, everything else will subsequently fail. So robotics and other AI technologies like the one you mentioned are very important.
For those of our viewers and listeners who like a bit of history, the Prometheus in The Dolphin Rider, there's a nice little story about him and liver regeneration for those of you who are interested. But like I told you at the beginning, we're staying in the here and now as opposed to in the past. So that was brilliant. So now we've obviously a nice highlight for liver. Let's go on to probably one of the most complicated organ systems in your body. And when it goes wrong, it can go dramatically wrong. That's the biliary system. And I remember when we were doing general surgery, and, gallbladder operations, just take them out. But when they go wrong, they are spectacular. And I'm so glad that HPB surgeons are around to help us out when it goes wrong. So do you want to tell me a little bit about the biliary system and not just gallbladder, of course, but the whole thing, and robotics?
Of course. So you correctly highlight that benign biliary disease forms a big chunk of the workload of any general surgeon, emergency surgery surgeon, as they're now emerging, and of course the hepatobiliary surgeon. They sit across all three. Easy peasy gallbladder happens everywhere, all over the world. We understand that the number one cause for a malpractice suit in the United States is common bile duct injury at the time of an easy laparoscopic cholecystectomy. Now, very well studied phenomenon. It is a, how should we say, it is a factor that leads to a shortened lifespan, no doubt about it, and it costs the taxpayer a lot of money in the payouts that happen. There is no doubt that there are certain scenarios that should only be dealt with by hepatobiliary surgeon. For example, common bile duct injury. We recently did a robotic repair in Copenhagen. It was just phenomenal. Rather than having a big cut, patient underwent minimally invasive repair. It was just phenomenal for the patient to have this and be avoiding a big cut and so on. The other scenario is that of two scenarios, where a subtotal cholecystectomy has been done elsewhere, and the robotic platform with its dexterity, its ability with its advanced instrumentations to be dissecting, the energy devices, the vision, just the whole package allows a completion cholecystectomy. Is not rare, but when you are faced with it, having the robot is a huge advantage. The second one is the fibrotic shrunken gallbladder with frozen callous triangle, where without the robot, you cannot get that traction, counter traction to separate this from the common bile duct, where it's often sitting on or plastered to, and is just a huge difference. So I think in both those scenarios, the robotic platform is a huge advantage to have.
So Aamir, that's a very good point. Let's just talk about that. You are in a frozen, let's call it a fibrotic zone, right? But let's take the shrunken gallbladder. That's a good example. You can't feel anything with the robot. You've got no haptic feedback.
Yes,
you've got better vision, of course, but your colleagues would argue that if you have an open operation, you can feel the tissue with your fingers, and therefore you may be able to manage that type of a difficult operation, in an easier way. An older surgeon like me would say that. How would you counter that with robotics? What is it about the robotics that makes that dissection of the shrunken fibrotic gallbladder easier?
It's the counter traction that you can obtain on the liver.
Okay.
Just one point in one line. You make a very good point. It's when you transition into robotics, you learn to make up for your lack of haptic feedback. I remember from my early days, I would be snapping stitches because I was just waiting for the signal to come to my brain that this is tight enough. And it never came till the snap came on, and then you understand that. Fine, you just got to look at it, start looking in a different way, and you don't need to be waiting for that haptic feedback to take place. So the problem with laparoscopic instrumentation or laparoscopic procedure is you just cannot get that counter traction. And tissue dissection, the robotic energy devices or sharp dissection on tissue under tension is what lends itself to doing these complex procedures. And it's just you then gain experience with it.
So I'll put a cost analysis to you about this for robotics. So we looked at single arm robots, okay, in gallbladder surgery. Because as you say, the counter traction, the liver, getting into that space, basically, how do you get in there safely? And how do you hold the liver out of the way while you're doing what you need to do? And the single arm robots may be more cost effective. So people have said to me, robots are expensive, but it depends on which type of robot you're using. So I'm just putting it to you. If you use, you may be familiar with the new single arm robots, as opposed to, you can put they're modular, they're called. You can put
Yeah.
1, 2, 3 arms, 4 arms all together if you wish. But each arm you take off, you save money in that operation. Now, with the high volume gallbladder surgery that goes on in the country or in many countries, it might be cost effective to use a single arm. What do you think about that?
So I think big programs will have more than one types of robot and match the OR that's available or that's required to the complexity of the surgery that's required. And that is now visible from several centers in the United States where robotics, because of the cost economics of their system, allowed large numbers of robots to be in one program at one time. So it's matching what is required to what is available. Yeah. And I completely agree with you that that will lead to a more cost-effective program to be put into place.
Yeah. I think, well, yeah. Well, hopefully we get you involved as part of these studies, because it'll be useful. Because I think even in the slightly complicated gallbladder operation, as you said, if you can get that retraction, the counterintuitive retraction, let's call it that, with a robotic arm, you are in a much better place to do more difficult gallbladder surgery.
Yes,
you made a very valid point. It just reminded me, so I thought I'd just mention it. So that's complicated gallbladder surgery. What about reconstruction? You just started to mention it a second ago with Copenhagen when you were there, but tell me what you think.
Biliary reconstruction. So biliary reconstruction for benign biliary disease. There's very few and far between now, because endobiliary stents are so good, and our gastroenterologists who do advanced interventional stuff are very good.
Yeah.
There is the case of common bile duct stones. We know that common bile duct stones are a part and parcel of benign biliary practice. We know that we avoid ERCP in patients who are young because of papillary stenosis. There's a few reports of them developing tumors. So we don't offer that. We recommend that young patients with common bile duct stones undergo minimally invasive surgery to retrieve those. The easiest way to do that is transcystic approach. I've done it. I've seen it. It's just an extended cholecystectomy, single operation, cleared. 1, 2, 3 days later, the patient is home. No waiting for ERCP. ERCP services in many hospitals are overstretched. Yeah. Patients wait. The revolving door, readmission. I've seen patients coming in 5 times. You've probably seen them. Risks of cholangitis, liver abscess, pancreatitis, etc. Then by that time, the gallbladder is fibrosed. It's not an easy operation anymore. So I think now there is, in the United Kingdom and elsewhere, segregation of emergency surgery and elective surgery, so that patients with emergency problems are able to get definitive care. In one hospital where I was recently, 50% of that work was benign biliary disease. Of that 50%, a third were common duct stones. So you're able to offer that. Now, robot offers an advantage in choledochotomy. In half the patients, the cystic duct is not wide enough to allow those stones or the choledocoscope to be. Now, if you have to do a choledochotomy in a young patient with a thin duct, it is not very easy to be stitching right down on where your instruments are.
Yeah.
Again, the dexterity of the robot offers the advantage. So I think if we had to sum it all up, in almost every aspect, the robot, some form of robot, would offer an advantage. Yeah. Of course, this comes at a cost, and that has to be built into the equation.
Yeah. So cost efficiency as well, but I think patient-centric clinical efficiency. I mean, what you're telling us is that you can get things done safely, effectively, early. I mean, you said that through all three areas of your specialties, so which is what I heard.
Yeah.
I mean, that's an amazing summary you've just given us. You clearly are a highly skilled, still young man. Look at you. You're looking so young. Jeez, we're the same age, you know, people are watching. You know, wow, look at this man. Perfect hair. So listen, it's been an absolute pleasure to talk to you. I before we go, I really would love to know a little bit more about you. So forget about work for a second, because something's keeping you looking young, yeah? So tell me a little bit about it. Are you involved with some, you know, high octane sport? You climbing mountains? You skydiving? What do you do when you're out of work?
All of the above.
Listen, I believe you. Windswept, I believe you. Well, what's your favorite thing that you like doing outside of work?
Well, obviously, I try and exercise when possible.
You don't have to exercise on this podcast. You can say you like red wine, and you know it's fine by me.
No, and I really enjoy playing golf.
Oh my goodness! Okay.
And if I had more time, I'd play more golf.
Okay, so I won't ask you what your handicap is, but I'll give you a game. I'll be your handicap probably. No. My level of being rubbish at golf, but we shall play, I'm sure. But listen, Dr. Aamir Khan, absolute honor and pleasure to talk to you today. Really giving us some insights into pancreatic biliary surgery. One of the best in the world. I'm happy to say he is, and he'll continue to be. And it's an absolute pleasure. And so from the Global Robotic Assisted Surgery podcast, I'm Professor Hitendra Patel. Have a good day. And thank you for listening and watching.
Thank you, Hitendra. Good to see you. Pleasure to talk to you.
Thank you for listening to the Global Robotic Assisted Surgery podcast, or GRASP for short. Please subscribe to be updated with all of our new podcasts coming out. If you would like to learn more about robotic assisted surgery, please go to www.roboticsurgerypodcast.com.